Multisystem, the Overcoming COVID-19 Network. This originated as a CDC-funded intensive care unit network led by Boston Children's Hospital to assess influenza vaccine effectiveness against critical illness in pediatric patients. It pivoted during the pandemic and now involves active prospective surveillance of MIS-C and severe COVID-19 in hospitalized children through a multi-center network of more than 60 hospitals in more than 30 states. We have a 60-plus page case report form, and this network has provided detailed epidemiologic and clinical data with interviews and biological specimens collected from a subset of consented cases. In addition to having an MIS-C and severe COVID-19 registry, which has provided a robust amount of detailed clinical data, other investigations in this network include a study evaluating risk factors for developing MIS-C, an immunobiology study aimed at elucidating host genetic variants that may play a role. We're conducting a neurologic and neurodevelopmental outcome study, and we also are doing ongoing studies of COVID-19 vaccine effectiveness. Next slide. So similar to the early slide showing manuscript contributions from national surveillance, these are some key manuscripts that highlight the contribution of the Overcoming COVID-19 Network to our knowledge about MIS-C. You can see that we gained valuable information, including a clustering analysis to help distinguish from similar inflammatory conditions. The neurologic involvement associated with MIS-C and severe COVID-19 has also been described. And in addition, in the front, I highlighted this paper evaluating associations between initial treatment with IVIG plus glucocorticoids or with IVIG alone and the clinical outcomes. And this figure shows the results of using two analytic approaches, both finding that initial treatment of MIS-C with IVIG plus glucocorticoids was associated with the lower risk of the composite outcome of cardiovascular dysfunction on or after day 2 than using IVIG alone. There was also a lower risk of the components of the composite outcome, including left ventricular dysfunction, shock, adjunctive immunomodulatory therapy, and persistent or recurrent fever. I just wanted you to have this as a reference, but you can essentially see that with all of the little boxes to the left of the dotted line, that it was showing that they were associated with the lower risk of those features. Next slide. This paper from earlier in the pandemic shows how these two surveillance platforms have worked together. We used the deduplicated numerator of MIS-C cases from both surveillance systems, from national surveillance and Overcoming COVID, and then we evaluated the incidence in two ways using two denominators. One was based on population and one on SARS-CoV-2 infections. For that denominator, we obtained this by using multipliers that had been published by our CDC colleagues accounting for under-ascertainment. So using that, we found an adjusted incidence of 316 MIS-C cases per million SARS-CoV-2 infections. To phrase this in terms more relatable, this is about the same as one MIS-C case in approximately 3,200 SARS-CoV-2 infections. And similar estimates have since been published from other countries. I would also just like to point out that incidence was highest among Black African American children and also higher among Hispanic, Latino, and Asian Pacific Islander children compared with white children. Next slide. So this is a little departure from MIS-C, but I did want to highlight these recent contributions of the Overcoming COVID-19 Network to studies of COVID-19 vaccine effectiveness, as we've been able to show some nice outcomes. Next slide. Okay, so here are the highlights of the results table excerpted from a figure from the New England Journal of Medicine paper showing the vaccine effectiveness of COVID-19 vaccination against COVID-19 hospitalizations in 12 to 18-year-olds overall by age group and among partially vaccinated children. Basically, the point estimates for vaccine effectiveness for all of these groups ranged from 94 to 97%. Next slide, or next click. I'm going to add a red box. So here I wanted to point out in the added red box that in addition to VE against overall COVID-19 hospitalizations, Among those 12 to 18-year-olds hospitalized, vaccine effectiveness against ICU admission and need for life support was 98% for each. Next slide. Okay, so here's the first of your self-knowledge checks. The following statements regarding MIS-C during the COVID-19 pandemic are true, except A, nationally, peaks of pandemic MIS-C activity follow peaks of COVID-19 activity by about 1 month. B, individuals aged 16 to 20 years comprise the highest proportion of MIS-C cases after SARS-CoV-2 infections. C, incidence of MIS-C is approximately 316 cases per million infections, which is about 1 case in 3,200 SARS-CoV-2 infections. Or D, MIS-C incidence is higher among Black, African American, and Hispanic Latino children compared with white children. So you're choosing the one that's not true. Next slide. And so the answer was B, because as I showed you, children aged 5 to 11 years have consistently comprised the highest proportion of MIS-C cases. And so with that, I will turn the talk over to Dr. Shana Godford-Cato to describe some of the work we have been doing with healthcare professionals and the materials that have been developed.
Thank you for that. I will be providing an overview of the MIS-C Healthcare Professional Project, including key findings and resources developed. Next slide, please. The Multisystem Inflammatory Syndrome in Children Healthcare Professional Engagement Study, which began in September of 2022, was designed to assess and address awareness, attitudes, knowledge, and resource needs among healthcare professionals from various clinical settings, including inpatient, emergency, urgent, and primary care. We conducted this project in 4 phases. Phase 1 consisted of an online survey with 272 healthcare professionals, conducted January 2021, and Phase 2 consisted of in-depth interviews with 24 healthcare professionals conducted in March of 2021. Using the data collected in Phases 1 and 2, we developed and tested materials designed to address key healthcare professionals' MIS-C informational and resource needs, as noted under Phase 3. During the final phase of the project, Phase 4, we engaged a variety of partners to support dissemination and monitored web traffic to and downloads of these new MIS-C materials. Next slide, please. We partnered with Medscape to assist with recruiting healthcare professionals for the Phase 1 online survey, the Phase 2 in-depth interviews, and the Phase 3 material testing. We developed a screening questionnaire administered by Medscape to ensure our surveyed population included only healthcare professionals treating pediatric and young adult populations. Healthcare professionals who reported seeing adults only were excluded. We also sought healthcare professionals working in inpatient, emergency care, urgent care, and primary care settings to participate in our data collection activities. And within these settings, we set quotas to ensure representation of MDs or DOs, PAs, and NPs. The next few slides will show a snapshot of some of our Phase 1 online survey findings. Next slide, please. One aspect we assessed was healthcare professionals' confidence in conducting a variety of activities related to knowledge of practice guidelines, diagnosis and reporting of patients with MIS-C or suspected cases of MIS-A. As shown on this slide, we asked healthcare professionals to indicate their level of competence as not at all confident, somewhat confident, or very confident. As you can see on this bar chart, we found that nearly 2/3 of inpatient healthcare professionals were very confident in assessing clinical and practice guidelines compared to just over 1/3 of emergency care, urgent care, and primary care healthcare professionals. The percent of healthcare professionals reporting not at all confident ranged from 7% of emergency care professionals to 13% of primary care professionals, as shown in the gray boxes at the bottom of each bar. Next slide, please. As shown here in the second bar chart, just over half of all inpatient healthcare professionals responded that they were very confident with MIS-C diagnoses, compared to 31% of emergency care, 18% of urgent care, and 21% of primary care healthcare professionals. Again, as shown by the gray portions of each bar, the percentage of healthcare professionals who reported not at all confident with MIS-C diagnosis ranged from 8% for inpatient healthcare professionals to 13% of urgent care and primary care professionals. Next slide, please. The third bar chart shows healthcare professional confidence in providing information required for MIS-C reporting. As you can see by the darker blue sections of the bars, healthcare professionals who report very confident with providing required information for MIS-C case reporting ranged from 42% for inpatient providers to 23% for primary care providers. As shown by the gray section of the bars, a range of 15 to 20% of healthcare professionals across settings were not at all confident with MIS-C reporting. Next slide, please. As part of the online survey, we also assessed healthcare professionals' level of confidence in communicating with parents and caregivers about the diagnosis, treatment, and follow-up of MIS-C. We saw significant differences in the level of confidence healthcare professionals had in talking with caregivers about MIS-C diagnoses or treatment across clinical settings, as shown by these bar graphs. As you can see by the dark purple sections, over 50% of inpatient healthcare professionals reported they were very confident with talking to parents about MIS-C diagnoses and treatment, compared to 35% or less across healthcare professionals from emergency care, urgent care, and primary care settings. Next slide, please. These next two bar graphs show that a smaller percentage of healthcare professionals across clinical settings were very confident when speaking with caregivers about MIS-C follow-up or answering MIS-C questions. As shown in the third bar graph from the right, 1/3 of all healthcare professionals or less reported they were very confident in talking to caregivers about MIS-C follow-up, again with the greatest percentage observed among inpatient healthcare professionals. Strikingly, we saw a range of 31 to 41% of all healthcare professionals who were not at all confident in speaking to parents about MIS-C follow-up. The bar graph on the right shows healthcare professional confidence in answering parent or caregiver MIS-C questions. Nearly 42% of inpatient healthcare professionals noted they were very confident in answering questions, compared to 20% of emergency care, 15% of urgent care, and 19% of primary care healthcare professionals. Nearly 20% of emergency care and 22% of urgent care healthcare professionals reported not at all confident. Across all four questions, inpatient healthcare professionals consistently had greater level of confidence in communicating with caregivers about MIS-C. Next slide, please. We also asked healthcare professionals completing the online survey about the most needed MIS-C resources, fact sheets, decision guide and algorithms, and materials to give to parents where the resource needs most cited. As shown by the first horizontal bar chart at the top of the slide, a greater percentage of emergency care, urgent care, and primary care healthcare professionals noted needing fact sheets compared to inpatient healthcare professionals. Nearly 2/3 of all healthcare professionals reported that they needed decision guides or algorithms, and between 41 to 58% reported a need for materials to give to families. Other resource needs cited by healthcare professionals, including medical association or professional society guidance documents and prompts in the electronic medical record. As shown by the second bar chart on this slide, when we looked at resource needs by healthcare professional type, we found that a greater percentage of nurse practitioners and physician assistants reported a need for fact sheets, and nurse practitioners reported a greater need for decision guides and materials to give to families. Next slide, please. From the in-depth interviews conducted in March of 2021, we heard firsthand about the key questions that remained about MIS-C. For many healthcare professionals, the lack of direct experience with seeing a patient with MIS-C was one of the biggest challenges. As illustrated by the quote shown here, the lack of experience made healthcare professionals feel less confident in being able to recognize MIS-C in their patients. Next slide, please. The flow diagram shows the process we use to develop the healthcare professionals' MIS-C materials and the key outputs from each step. As shown in step 1, we synthesized survey and interview data to develop a list of priority healthcare professional resources needs related to MIS-C. We used this list to develop material concepts, which resulted in the recommendation to develop 4 MIS-C informational materials for healthcare professionals. Once the materials were developed and designed, we conducted testing with a sample of 282 healthcare professionals to ensure the materials met their needs. Similar to the phase 1 survey and the phase 2 interviews, we included MDs or DOs, PAs, and NPs that work in inpatient, emergency care, urgent care, and primary care settings. Feedback collected from the original material testing survey provided insights about